Well, certainly healthcare continues to be at the forefront of minds as we head into 2022. The coronavirus continues to be a part of our everyday life with the Omicron variant, the latest one kind of in the mix. So what does this mean for healthcare overall in general? Dr. Ezekiel Emanuel is Vice Provost for Global Initiatives, as well as Chair of the Department of Medical Ethics and Policy at the University of Pennsylvania. Zeke, great to talk to you again. Hope you're doing well.
Thank you very much. Yes, it's been great.
So let me start kind of with an overview of 2021 and how you think the healthcare sector in general was able to get through the year with all of these different elements at play.
Well, there's not one answer. Let us just say, I do think when the Biden administration came into office, hard to recall, but that's a year ago, January 20th, they had a playbook to execute on getting vaccines to Americans. And frankly, it wasn't flawless, but they executed really, really well. They got tens, hundreds of millions of Americans vaccinated. There was a first cohort, as we all know, the willing, somewhere between 35 and 40%. Made a difference, seemed to have the virus come down. In early June, things were looking great. Late May, early June, CDC said, take off your mask famously. And then Delta hit, and it wasn't in the playbook. And I think since that time, we've really been struggling. We sort of hit a plateau of about 60% of Americans vaccinated, which is a real problem because we need to be higher at 80, 85%. We've seen the need to implement mandates. I called for a mandate on April 14th, which was the peak day of vaccinations. And it was clear to me, even when we were giving out 3.3, 3.4 million vaccines per day, we weren't going to get to where we needed to be voluntarily. We've never gotten to 85% of the population doing anything voluntarily. And so it was clear to me mandates were necessary. We've slowly rolled out mandates, first healthcare workers, the military, the VA, healthcare workers, and now all employers over 100, assuming that OSHA can win its legal battle. I think there are still things that need to be done on that front. Then Delta hit, cases have gone up. The holidays, there's no doubt that in early January, we will have we're already in a big a surge, and we're going to have a higher surge. I don't think it's going to be as bad as the start of 2021. People, again, may not remember, but we had a huge surge. More importantly, we were having 3,500 deaths per day. I don't think we're going to get there because so much of the population is vaccinated, but we could get over 2,000 deaths per day, which would be double where we are today, more than double where we are today. And that's a worrisome sign, that we have an effective vaccine and people are sort of not taking it up. The other piece of good news here is the potential oral therapeutics. They could have a very big effect. Now, it's a little more complicated because they have to be taken very, very quickly after you have symptoms or know you're positive. And we don't have that tight link between the testing system and doing something, either getting people in studies, getting people oral therapeutics, getting people monoclonals. That actually has been one of the biggest failings, if you ask me, of the current system. The testing has not been linked to the rest of what we need to be doing. So on the healthcare system, I think if you had to take away a big lesson here for the healthcare system separate from COVID, COVID has induced big transformations in moving out of facilities, out of hospitals, out of offices, whether it's more home care, more telemedicine. How that sticks, how it's coordinated, that's still a work in progress, frankly, and will be a work in progress. You are seeing a lot of startups come into the space. Who survives? I think it's going to be the startup that can give you one-stop shopping and really coordinate the continuum of non-institutional care. We don't have that company yet, but I think that's where we're going. So a doctor or nurse practitioner or someone can say, home care for, and everything you need, whether it's antibiotics, an IV infusion, a hospital bed, a laboratory test, can be done pretty seamlessly at the home over remote monitoring. I think that's, again, we're not there, but it's inevitable. Although how long it'll take, I think is a little unclear. And then, of course, the payment system is going to have to catch up on that ballgame.
So as you were saying that, in my mind, I was thinking about something that we've talked about a lot from the business perspective during this time of the pandemic, and that's how so many businesses have had to pivot during this time to be able to stay alive, keep their business operations running. And what you're laying out there seemingly is a pretty large pivot, I think, in many cases, in many sectors of the healthcare sector as we move forward over the next couple of years.
Oh, yeah. I mean, I think the healthcare sector over the last decade has been moving slower and then a little more rapidly. But yes, it's going to be a pivot. And I think, again, just to reemphasize, Dan, it's going to be induce long-term changes in the healthcare system. Just like we're seeing long-term changes in the labor market with the Great Resignation, more work from home. We're going to see in healthcare, again, more home, more care that's virtual. And I think in general, that's something I've been advocating. I happen to go back to my 2014 book, Reinventing American Healthcare, and, basically said we're going to be moving out of the hospital and the four walls of the physician's office. And, it's probably taken longer than I anticipated, but it's definitely entrenched.
Let me ask you about the telehealth movement, which is something we've talked about in the past, and you've talked about the importance of it as we move forward. Where does that stand right now, do you believe, in the scope of having to deal through the impacts of the pandemic and where it's headed forward?
Well, in some ways, and this may horrify some people, it's kind of like electronic health records. Before the pandemic, hardly anyone used them, right? Before the Affordable Care, the High-Tech Act, hardly any health systems used it. And then suddenly you're forced to use it. It's not pretty. There are a lot of kinks. Same thing here. It's not, it's not seamless. It's not wonderful yet, but we're forced to do it, and we will accommodate. But what we have seen is a big uptick, and then it's really dropped back down, partially because of payment, partially because of being able to give advice across state lines, and a lot of other HIPAA rules related to privacy, and et cetera. That'll all be worked out. I have no doubt about it. And as more doctors and health systems go to risk, telemedicine will find its niche in the appropriate care.
Is there a linkage, do you think, then, because obviously payment systems have developed on a technological standpoint in general, but is there a linkage between the success we're now seeing with payment systems just in general in the public and how payment can work in the healthcare sector using that technological aspect?
Well, again, part of the issue is the worry that if you pay for it, it'll be in addition, not substituting for regular in-person care, and that'll just add costs. So I think figuring out that happy medium, how you pay for it, and it substitutes, it doesn't, it's not additional, is I think what everyone is trying to work out. And the best way to do that, frankly, is put the providers at risk. Then they'll figure out how they need to integrate it. When they're at risk, for example, we know, for example, post-surgery, they send patients home, they do home PT and things like that. They figure it out, and we need to we need to empower the provider to figure it out. It's not something that really payers ought to be figuring out.
So as we move forward, we've had the Delta variant, we have Omicron. Is there an element that we should expect that we're going to be dealing with virus of some kind from this for a significant period of time moving forward?
Absolutely. I mean, we're not getting away from coronavirus. It's here to stay. It's around the world. What we will do is see it more as like the flu. It's just in the air, as it were. And I think we need to actually reorient. So getting into the weeds a little bit, but the weeds here do influence how we think about things. You know, when the CDC and others look at respiratory illnesses, they say pneumonia and influenza. I think we have to separate pneumonia, bacterial pneumonias, all of those things. That's one category. Viral respiratory illnesses, the flu, adenovirus, para-influenza virus, and now coronavirus, that's a different category. And so we have to reorient the viral respiratory illnesses and the bacterial respiratory illnesses and look at them separately. And I think we need to get into a position of where we really can monitor all the viral respiratory illnesses. We have the capacity, we've just not deployed it, and get it much more real-time analysis. You know, wherever a hospital is reporting, we have multiplex diagnostics so people can figure out, yes, we're seeing this uptick in influenza or para-influenza or respiratory syncytial virus, and we actually know what's happening in the community. I mean, I think one of the things that's been made clear, if not to the public, then certainly to policymakers, is a lot of what the CDC was doing was really flying by, just sort of, you know, using a model and grabbing numbers. It wasn't real data, it was modeling. And we need more real data, and it has to be real time, and it has to be all the hospitals, the physician offices, increasingly pharmacies, the ability to monitor and do rapid tests. We, again, need to invest in it, but with a whole data infrastructure as well as the tests. But I think that's where we're going. Coronavirus is going to be here. Hopefully the orals will take care of it, and we'll get better vaccines that are pan coronaviruses, if not pan coronaviruses, then really can quickly adapt.
So as we turn the calendar to 2022, where is your focus of most interest going into the year for the healthcare sector? What are the elements that you are most watchful of?
Well, I think the question is, when do we get coronavirus so that it's not felt to be a health emergency dominating the front page of the paper and floats into the background? Prior to Omicron, I thought it was going to be kind of April, May 2022. If Omicron turns out not to be severe, then that might hold. If it turns out to be more severe and really have complications, especially in the elderly, then that'll be pushed down the line until we get a vaccine. I don't know how to do this. I can tell you what the imperative, that's not that I know the path there. We need to stop making vaccines and vaccination a cultural issue and just make it a scientific medical issue. Having people mandated for vaccine is not it's not a big issue about, are you for freedom or against freedom? It's, are we going to live together and respect each other and protect each other's health? And that's, I think, going to be really important to do, because we're going to have to get a very high vaccination rate, and we're just not there yet.
Zeke, as always, great to get your insights. Thanks very much. Wish you a great 2022 too.
Yeah, wish you a great one, and all the listeners a great 2022, and hopefully we'll get coronavirus in the background. I know that I, like many of your listeners, really want to get back to a life where we can do the usual things. We can travel, we can see family without masks, we can go to restaurants and theater and concerts without masks, and that will be, I hope that'll be the legacy of 2022 for all of us.
Dr. Zeke Emanuel, who is Vice Provost of Global Initiatives, as well as Chair of the Department of Medical Ethics and Policy at the University of Pennsylvania.